Hello, everyone. My name is Dr. Maureen Onweni. I'm a third-year medical resident at the Augusta University, University of Georgia Medical Partnership Internal Medicine Program. Ooh, yes, I know. That's quite a mouthful. The title of my poster is A Case of Hepatic Hydrothorax Without Ascites. Hepatic hydrothorax refers to the presence of pleural effusion, usually greater than 500 ml, in a patient with cirrhosis who does not have other reasons to have a pleural effusion, such as cardiac, pulmonary, or pleural disease. Usually in patients with ascites, they can tolerate up to 5 to 10 liters of fluid with only mild symptoms. But when they do develop pleural effusion, they can come in with severe symptoms such as shortness of breath, cough, and hypoxemia with as little as 500 ml of fluid. I present to you a case of a 72-year-old female with an 11-year history of non-alcoholic cirrhosis who presented with altered mental status and was found to have high ammonia level. She was subsequently diagnosed with hepatic encephalopathy, treated with rectal lactulose, and transitioned to oral lactulose as her mentation improved. Her hospital course was complicated with sepsis-like signs with no identified source of infection, and she was treated with IV Zosyn and later transitioned to oral Levaquin. Chest X-ray was obtained, which showed a moderate-sized left pleural effusion, as you can see in the middle portion of my poster. Subsequent CT chest showed similar findings. Pleural fluid analysis from thoracentesis was mainly transudative based on Lyle's criteria with no signs of malignancy or infection. And CT abdomen that was obtained showed no evidence of ascites. Echocardiogram showed a preserved ejection fraction, no diastolic dysfunction or valvular abnormalities, and other laboratory data showed no evidence of renal dysfunction. She was discharged with spironolactone and Lasix, 100 milligram and 40 milligram respectively. It is also important to note that this particular patient has never had any history of ascites, hepatic encephalopathy, or varices. When you look at the middle portion of my poster on the second image, which is the CT scan of the chest, yes, that shows the left-sided pleural effusion, and that was reviewed thoroughly. The whole CT chest was reviewed thoroughly and showed no evidence of parenchymal lung lesion or pleural thickening. My case highlights the importance of identifying a transudative pleural effusion as hepatic hydrothorax when there is no alternative reason, even in the absence of ascites. Literature review showed a particular case where the first sign of liver dysfunction was hepatic hydrothorax, and that patient in that case was diagnosed with cirrhosis. It's also important because this helps to direct management and also improves the outcome for the patient. The mainstay treatment for hepatic hydrothorax is dietary sodium restriction and diuretics, and patients are also referred for liver transplantation. And if they do fail with the dietary restriction and diuretics, then other treatment plans include serial thoracentesis, TIPS, thoracoscopic surgery, and liver transplantation. In conclusion, I hope my case will increase awareness of this presentation, which will allow clinicians to identify hepatic hydrothorax as a differential diagnosis for transudative pleural effusion, even in the absence of ascites, which will ultimately improve overall outcome for patients. Thank you for your audience. Below are my references, and I have no disclosures to declare.